That looks perfect. Awesome. I see everyone is coming back. Martin, hello. All right, guys. Let's welcome Debbie, who is here to present her afternoon report. Debbie, you take it away. You just gotta
All right. Okay. Hello, everyone. Hi, I'm Debbie, and I'll be talking about this patient who came in with a chief complaint of fever. So this patient is a 63-year-old Japanese male with past medical history of meningioma, presenting with fever of 2 weeks. So this patient that I'm talking about was a patient that I saw in the ED. So 2 weeks prior to that, he reported having cough, fever, and chills, and he consulted his primary care doctor, and he was diagnosed then with bronchitis and was prescribed a 7-day course of antibiotics. A week after, he completed this antibiotic course, but still had daily recurrences of fever with maximum temperature of 104, accompanied by chills, diaphoresis, headache, anorexia, and weight loss. And then 4 days prior, he reported dark brown urine that he said resolved after a day. And then the ED, this time he is presenting with sharp left lower quadrant pain and frank hematuria.
All right, sounds like there's a lot going on.
Yes.
So someone coming in with fever, and they had a few symptoms here that you already mentioned: cough, fever, chills, and then that's when he went to primary care, prescribed antibiotics. Does anyone have any questions for this patient as they're walking into the ED and you're reading their history? What else would you like to know? This is someone, and bear in mind that they completed a full antibiotic course, but they're still having fevers and some other symptoms. What are you guys thinking about here, and what other questions would you like to know, or things would you like to know?
When was the meningioma diagnosed?
Actually, this meningioma was diagnosed more than 20 years ago. It wasn't talked about. This wasn't a long time remission and was never active. So aside from that, he doesn't have any past medical history.
Has his respiratory symptoms improved since taking the antibiotics? Does he still have this cough? Is he breathing comfortably, shortness of breath, anything like that?
The cough has resolved after that week of antibiotics, but when I saw him, he was not in any respiratory distress. He looked comfortable except for when he moves in his left side, and he was having this frank hematuria in the ED.
I'd want to ask is he having any like GI symptoms like diarrhea, for example, since he's coming into the ED with abdominal pain?
No, he had no bowel changes, no diarrhea, no constipation.
What
No.
about
How much weight loss has he had?
He had approximately 5 pounds in a week.
Where does he live, and where's he? I guess the question is, did he live in a different country before coming here? And where does he live now in New York City?
Yes, he lives in the city. He lives in Midtown. I'm not sure where he grew up, probably in Japan, or maybe he immigrated here, but he's been living here in the city for the past years.
I have 2 questions for you guys before we move on. First one is, Adrian, you brought up the topic of diarrhea, and I'm wondering if there's anything else in the patient's symptoms other than the abdominal pain that you may think of that could be linked to diarrhea. And then maybe Bailey, and this is just food for thought, and we can keep on asking any questions. Bailey, you're mentioning, what are their demographics? Do they have any exposures? Is there anything, and I don't mean to put you on the spot, anything that you're thinking about? And you mentioned also where in New York City. What are your thoughts around this?
So I was thinking if he lived elsewhere besides New York City, like maybe he was exposed to TB because this fever, the weight loss. I think it says that he had chills, sweating, headache. And then if he did live in New York City, like things such as like Legionella, I'm not sure if like those kinds of infections cause weight loss, but like definitely if you're super sick, having recurrent fevers, not on the right antibiotics, it could be a possibility that he got something from living here in close quarters with someone.
That's very interesting. I'm going to take advantage of the fact that Dr. Sawyer is here. I don't know if, Dr. Sawyer, is TB something that you would expect to see? And again, Bailey mentioned outside of New York City, would that be something that you would have in mind when someone presents with symptoms like these, if they lived
I mean, I think to me, it has to be part of the difference. I think the only thing you have is just the acuity because it's 2 weeks. So you would just want to get more history in terms of medications or like any concern for immunosuppression and like a little bit further history. So I think for me, it's just the only thing against, like when we go against or versus for, it's just the acuity, but it's not like I remove it from the differential. I have to get more information, which I'll wait for to ask, but if you're already asking, should I put this person in isolation or not? I think I need to get more information first, because that's always the question we get when someone gets admitted is, do we need to order AFB sputums and put them in isolation?
Mm-hmm. And this is obviously pre-COVID times, just a whole different story. But we would be considering that at this point. Oh, and I apologize, I haven't been checking the chat, but Victor had asked about travel history. I think that was already answered, and Sherelle wanted to know about any blood clots in the urine.
So in the urine, no blood clots, and the blood, the frank hematuria was present all throughout the micturition.
And then in the same, does our patient have any family history of any kidney disease? And I'm wondering, Sherelle, if that's related to, like, if you can tell us which symptom are you referring to or which sign, and where your question's headed.
Mainly because of the hematuria. That's why I was wondering.
Gotcha. Yeah, that makes sense. And then it goes in line with what Richard is suggesting, maybe a previous infection and maybe the diarrhea that we were mentioning before. Could this be HUS? Jonathan wants to know if they are also experiencing pain with urination.
No, he denies any burning sensation or any dysuria, and it's a painless hematuria.
And then Nadine, you have a few questions here, and I'm wondering if you can, if you don't mind unmuting yourself and just kind of walking us through why you're asking all these questions to the patient.
So like he has a fever, and I think a broad category on the differential is infectious. So I would like ask very broad questions. One of the things to potentially rule out someone with a fever and a headache, like, do they have any meningeal signs? Could this be a meningitis? And so I would want to know about like the neck stiffness, the neck pain, and then just any other neurologic symptoms. Like I would think it's important to see if he reports anything before we get to the physical exam.
I see, that makes sense. We're keeping it broad for now, even though we have some concomitant symptoms, but you are also saying, well, they might have a fever and a headache. Could this be anything that they related to a neurologic or a CNS infection? And then Bruno, you're asking about if the patient smokes or if they have a history of cancer. I'm assuming this is related to the weight loss and other constitutional symptoms.
Yes, so I can go to my next slide to show family history and social history. So the only past medical history is meningioma, no allergies. This was in August last year, so he received 1 dose of COVID-19 vaccine and he's not on any medications. No recent overseas travel. Family history is positive with a lot of cancer. Mother and father died. Mother died of breast and skin cancer. Father died of stomach cancer. Sister is living, had a history of leukemia. So he's retired. He lives with his wife in the city. He ambulates independently, never a smoker, drinks one standard drink per week, and denies any illicit drug use.
Anything that stands out to anyone here? Are your questions answered, or do you need more history on this patient?
Can I ask one more question? So basically he came in or he went to see his PCP with a fever. Was that also 104 or was that a little bit lower? Because 104 in an adult is very high.
Yes,
Um,
it played around 102 to 104. So it remained high even after a week of that antibiotic course.
Sorry, and I know it was an appear site. When was it that he showed up to the PCP? Like,
Um,
from symptom onset.
He showed up after 3 to 4 days of cough. So it was almost like 4 to 5 days of fever, cough, chills when he was seen by the PCP. The fever will lower down with Tylenol, but it will come back up after 6 hours.
That's
daily.
another important question. What was the frequency of the fever? Did it follow any specific patterns?
So it was daily, recurrent fevers, 102 to 104, would lower down a bit with Tylenol, but then it would come back up.
And when you say they didn't have any overseas travels, but this is someone that has stayed in New York City.
He stayed in New York City, but every year he said that there were times that he would visit his family in Connecticut.
Interesting. Okay.
Was the cough productive
sorry.
at all? Sorry. Like,
Can you
Go ahead,
repeat?
Tyler.
was the cough productive at all, or like was there hemoptysis?
No, it was a dry cough, non-productive.
Had he visited, because you fell into that, but had he visited Connecticut in the last 6 months?
He visited a relative 2 months prior. And he stayed there for a bit because he has family there. He does this every spring to summertime every year.
I'm sorry, I ignored your question initially, Victor, because I knew where that would lead. He wants to know if the patient had any skin rashes that he noticed at any point.
No skin rashes at all.
Any hiking, outdoor activities, going to caves, anything of that nature?
None. He just stayed at home with the relatives.
Does that answer your question, Bailey? Cool. And then before we move to Richard's question, Daya was saying that everyone in the family had a history of cancer. Could there be a pattern to this? And that is definitely, that's very interesting. It's also stomach cancer. I mean, could it be, are his parents back in Japan? Could that be related to something else and some sort of exposure? We may not know the answer.
Yes, I actually do not know some of the answers to your questions.
Well, that's interesting to note for sure. And then Richard wanted to know, because we're thinking of, could this all be related to something that's running, could be cancer, which could cause fever, but I don't know if this would be such a high fever. Richard wanted to know if they have any pets.
No pets.
Okay. And which pets are you thinking about, Richard?
Like cats, dogs, parrots. Particularly the cats
How come?
for
You're thinking
Bartonella.
zoonosis? Mhm.
Like Bartonella, Pastorella, those types of agents. Even toxoplasma can cause those symptoms.
And I, of course, wanted to know if he was exposed to any wild animals. I'm guessing when he was in Connecticut.
I have no idea if he was exposed to any wild animals, but I'm not sure about that actually, but he said that he just stayed at home with his relatives.
So he wasn't camping. He wasn't in the wilderness.
No peculiar activity for him.
All right. I think we know where this is headed. Bruno, what's your question? What did he used to work with? Why are you asking this question, which is definitely really important?
I was just wondering, trying to see if he has any other risk factors for renal cell carcinoma or bladder cancer that could, there are two things that could explain his symptoms.
Yeah.
He used to work corporate in a corporate company, so he's
Gotcha.
a businessman, so he doesn't have any exposures to those.
And Bruno brings up a good point, like we're thinking, yes, I might debugs, but malignancy and fevers, thinking of not ruling out, is this also be inclusive from just a malignancy that's underlying as well?
One thing that also brought my attention, I don't know if the hematuria was something that was recurrent. So I remember from the initial HPI that he had like an episode of brown urine, then it
Yes,
resolved, and then he had the gross hematuria afterwards. Is that right?
that's right. Those are the only episodes of hematuria for him.
Okay.
Very
So
good questions.
if we put everything together, let's go group by group in our differential with the information we have by now, at this point. So, people have mentioned cancer, and that's very appropriate. Bruno mentioned renal cancer, which makes a lot of sense because it would explain the hematuria, it would explain the fever, right? Renal cancer is famous for giving fever. Any other cancers that people can think of?
Multiple myeloma.
Okay. How would that explain the presentation?
Just the fevers, weight loss, hematuria even. Some of the presentation. not all.
Hematuria is typical, right? Because multiple myeloma gives you more infiltrative type of disease when it gets there. So it wouldn't be high on my list, I would say. Lymphoma, because of the fever, against the hematuria, lymphoma may infiltrate the kidney and it gives you mostly an interstitial disease in the kidney. So it won't be like a typical presentation, the hematuria with lymphoma either.
Bladder cancer, maybe with the painless hematuria.
Okay. If we have to compare kidney with bladder, I think I would favor renal versus bladder in the sense that bladder doesn't, unless it's giving you obstruction, it shouldn't really give you fevers, right? Besides cancers, well, we've already mentioned many infectious diseases. One comment I would make is if you were the patient's PCP and this patient comes to you with a fever, would you have given those antibiotics to patients? Thinking it's a bronchitis.
I see many heads shaking now.
What is that?
I don't get the clarithromycin at all. It's a very.
I don't get any of the antibiotics at all.
Yeah.
I mean,
very,
for bronchitis, you don't give antibiotics, right? Most bronchitis are viral.
right.
So
But
it's
if you're
not
taking pneumonia, like the Augmentin at least has a option in my head, but clarithromycin is weird.
Okay, I agree. But then, bronchitis is different from pneumonia, right? And if we don't know what the PCP was thinking. I agree with you that PCP must have been thinking of pneumonia, not bronchitis. But if it was bronchitis, there was no indication. What other categories of diseases should we consider?
Rheumatologic is another cause of fevers that it's important.
Absolutely. So what rheumatological disease could give you cough, fever, and hematuria?
I think it would be Wegener.
Good
Okay.
as well. I don't know.
Okay, yeah, I would go more on the good pasture type of disease. If we're thinking something on the vasculitis type of diseases, including lung and renal. But yes, I agree that, that type of vasculitis should be considered on the differential for this patient as well. Any other category of disease?
I guess the reason why I was asking my question before is if he had a fever of like 100, and then after he got those drugs, he had a fever 104. I was thinking maybe like a drug fever, which could cause all of the renal complications.
Yes.
So I guess another question we could ask is, has he ever been given those antibiotics before?
Absolutely. I totally agree. The guy came in with some fever, got antibiotics, and things got worse, apparently. So I think we need to think of that and probably very high on the differential. He could have had an interstitial nephritis. He could have had something that bled into the urine. Anyway, Fermin Debbie gave us some, a tip when she said hematuria, because what we know is that he had dark urine. It could have been blood, it could have been myoglobin, right? Giving you dark urine. But we know we already know that's hematuria. So no, I agree. I think those are the main categories that we have to consider. Maybe not the only ones, but those are probably the main. And I agree with Tom that a drug reaction should be very high on this differential.
Okay, should I continue?
Yeah.
Okay. So for review of systems, just to quickly summarize everything. So he's positive for fever, chills, diaphoresis, anorexia, weight loss, cough, lower left quadrant pain, dark brown urine and hematuria, and headaches. Do you want to go through the physical examination now?
Go ahead, Debbie. Yeah.
All right, so in the ED, patient's blood pressure was okay, 128/86, tachycardic at 118, temperature of 101.9, satting at 95% in room air, not in acute distress, tachycardic, no abnormal heart sounds, with direct tenderness on left lower quadrant, no rebound, no guarding, normal bowel sounds, and left CVA tenderness. He also don't have any rash, no jaundice, no leg edema, and neurological, he was alert, oriented to person, place, and time, and had no focal deficits. No neck rigidity as well. Okay.
Before we go to the workup, does this physical exam change the way we think about the differential?
You want to consider something like pyelonephritis because of the CVA tenderness, particularly. So like kidney stones, pyelonephritis, that kind of stuff.
The only other thing I think I would add is with like tachycardia, fevers, I don't know, endocarditis, like septic emboli.
Interesting suggestions for sure. Although the fever itself can give you tachycardia, of course, and you would see other maybe things, other skin abnormalities. Any more questions for you guys before we move on?
I would ask, maybe has the pain like changed at all in terms of like the abdominal pain? Has it like moved from one location to another? Because like if I'm thinking kidney stones, potentially like seeing if the stone is moving through the urogenital tract.
So the left lower quadrant pain was new that day when he presented in the ED. So it just remained in the left lower quadrant, not radiating to anywhere.
If you want to move on, Debbie?
Okay. So for the initial workup, what do you guys want to request or order?
Just type in the tag. Come on. This is a patient walking in the ED. We've had a very long discussion. There we go. We have a UA. Of course, the CAC, BMP, and blood cultures because they're febrile. You want to see if there's end organ damage. We'll have some collection of lactate. Jonathan wants to go all the way to CTAB. We maybe start with the next one. All right, and then we'll collect urine cultures if the UA is positive. We need an abdominal ultrasound if we're suspecting there's a kidney stone. Cost effectiveness, I love it, fantastic. All right, what do you order, Debbie, for this patient?
So these are the laboratory tests that we ordered in the ED. So for the patient's CBC, patient had a slight low hemoglobin, but the pertinent thing here is the platelet of 38. White count is within normal limits, but had a predominance of monocytes. And we also got coags for him. PTI and R were okay, but he had a prolonged PTT. Okay, and then we also did CMP for him. So he had an elevated creatinine as well, slightly elevated LFTs, negative trope, negative BNP, and urinalysis showed RBCs, protein, and WBCs, but negative leukocyte esterase and nitrites. Lactic acid was elevated to 2.24.
Do we have any baseline labs for this patient, Larry?
Unfortunately, we don't have any. He doesn't have anything from Care Everywhere as well. So we don't know if this creatinine is elevated creatinine is new, or this is like a chronic thing.
The mild transaminitis and the elevated bilirubin.
Yes, the transaminitis. Yes, there's some
I don't know.
transaminitis as
Yep.
well. Okay. And then we also did an EKG for this patient because he was having tachycardia. So the reading, I'm not sure if you wanna.
That's okay. You can tell us what you
Okay,
see.
so the
Okay, you got it.
reading here had no abnormal waves, just sinus tachycardia. And then we did a chest X-ray as well, which was unremarkable. Did not show any opacity, any haziness, no pleural effusion. And then we also ordered a CT abdomen and pelvis. So here, this is, I believe with CT, there should be a lot of cuts, but these are the two that I got that are, I think, representative of the finding. So the spleen was enlarged with lobulations. And in this film, you can see this wedge-shaped hypodensities that could be representing splenic infarcts. So, and the CT abdomen and pelvis, it did not show any urethral or renal calculi, no hydronephrosis, but an enlarged spleen and splenic infarcts. We wanted to do a TTE as well for him, but it was done the next day and it was normal. Ejection fraction was normal, no valvular abnormalities or wall hypokinesia or dilation. And then,
why was the TTE, why was that suggested, the TTE?
I think they were also thinking of endocarditis.
Oh.
So they wanted to do that to rule that out, but it was negative. And then
Did
we
they
did
follow with the TE?
Sorry?
Did they follow with the TE after the transthoracic echo was done?
Did we
Just wondering. Did they do any more testing?
I'm not sure.
Okay.
But I think that was ruled out when that first TTE was done. But in the ED, we did hemolysis labs as well. After hydrating the patient, lactic acid was normalized to 1, and then haptoglobin was less than 8, and LDH was elevated. We got a direct Coombs test as well, which is negative. So just to give you quickly a quick summary of all the workups that we did for this patient. This patient came in with very low platelets, a thrombocytopenia of 38, a prolonged PTT, an elevated creatinine, elevated liver function tests, urine with positive in protein, RBCs and WBCs, a lactate that has resolved, sinus tachycardia, normal chest X-ray, splenic infarcts, and splenomegaly seen on CT AP, and positive hemolysis labs.
At this time, blood cultures, you knew them or they were negative?
The blood cultures were drawn this time.
Okay, but you didn't know the result yet.
No.
All right, who wants to take a stab at the problem for presentation? Still have my second rule after which I'm gonna, there you go, Nadeem, thank you.
Oh, wait, you want us to just summarize the case, or?
In a one line, remember, patient characteristics and there we go.
So he's an elderly gentleman, originally of Japanese descent. He's coming in with fever for 2 weeks. He also has associated headache, weight loss, and hematuria, as well as abdominal pain and back pain, like CVA tenderness on exam. He's a non-smoker, but does have a significant family history of cancer. And on workup, he was found to be thrombocytopenic. CT of the abdomen pelvis showed splenomegaly with splenic infarcts. I think that's it.
Great, thank you, Nadeem. Oh, there we go.
Yes. So I think Nadeem got almost all of it. So he's a 63-year-old middle-aged man presenting with subacute fever with accompanying systemic symptoms of recurrent fevers, chills, diaphoresis, poor appetite, weight loss, found to be febrile and tachycardic with left lower quadrant pain and left CVA tenderness and hematuria, severe thrombocytopenia, elevated creatinine, LFTs, positive hemolysis labs, and large spleen with splenic infarcts found on CT-AP. Okay, so given this one-liner, what do you think are the differential diagnoses? We can go back to the one-liner.
There are a few good questions that came up in the chat as well, and they were wondering if we already have a peripheral smear available, which definitely would make sense just given the labs that we've seen. And Tom was wondering if we had gotten complement levels for him. I know that this might not have happened initially in the ED, but in the course of the hospitalization, Debbie, do you know if we have a peripheral smear or
Yes,
complement level?
the peripheral smear was done. It was done in a daily basis. It showed rare schistocytes.
Okay.
But other than that, nothing was seen initially.
Which kind of would go with the rest of the labs that we're seeing are consistent with hemolysis. So now we're thinking, what are we thinking? There we go. So HUS, KTP, malignancy. And then Nadeem thinks that of these malignancies, leukemia should be considered. Lisa's thinking, could the splenic thrombosis be due to meds, or is there anything else going on there? Maybe some microangiopathy. Are we still thinking, could this be infectious, autoimmune? You can keep all, I know we discussed this in length, and just looking at the time, I know that antiphospholipid syndrome is now coming into the diagnosis, or the differential. So it looks like we're still keeping it to broad categories. Did we send the dimer initially or fibrinogen?
Yeah, we did. They were all elevated. Fibrinogen and D-dimer were elevated. Okay. Danny, should I go ahead?
I think so, Davi. I think so. People are still thinking it's still quite broad, but we're thinking hemolysis.
Okay. So I think this is the discussion part on how.
Cool.
Yeah.
Cool. So this is where I steal your screen. Now we'll keep it brief because this has been, can you guys see my screen? You can. Such an interesting discussion, so I won't take much of the time that we have. The main thing is, how do we generate that differential diagnosis? I'm going to focus on isolated thrombocytopenia because this patient has a lot going on, and I think the discussion that he's going to bring is far more interesting than what I can offer at this point. But I do want you guys to take the point of what initial testing you did. All fantastic job, just making those suggestions. What should we order when we see a patient with thrombocytopenia? And of course, the first thing that I was looking at is what is our definition for thrombocytopenia? ideally less than 150,000. Now, I was reading the literature that some authors would suggest that platelets in between 100 and 150,000, as long as they've seen the level stable for at least 6 months, maybe consider a normal level. I don't know that this has changed in any of the formal guidelines for the cutoff for thrombocytopenia, but I do think it's interesting to consider this in otherwise healthy individuals that have not experienced any change in their platelet levels. Now, if I can offer anything today, it's a simplified approach to thrombocytopenia, and at least I think 3 steps. So for you guys to know, all that we are using today, both Debbie and I, comes from these resources. I highly suggest taking a look at the NEGM 360. They have fast facts on thrombocytopenia, and I think they also do an amazing job at sharing their algorithms and a few other resources that I use for this presentation. And if you Google my name and type thrombocytopenia and PRESI, you'll find all these online. So like I said, how would I approach thrombocytopenia in different settings, whether this is the first time I'm seeing this patient as outpatient, or whether I see them in the ED or in the ICU. We'll try to go through this. The first thing, we want to make sure that we're excluding, spurious thrombocytopenia. So is this artifactual? And the first thing that we can do is just repeat the CBC, right? That will be the first step in actually treating thrombocytopenia, because that's a possibility. And of course, if this is true, thrombocytopenia, could this be just incidental? Could it be a healthy individual and I'm just staring at a healthy woman who's pregnant and has a thrombocytopenia? That would be expected in her case. Now, I included this because this is what we use to collect our labs. For the CBC, as you can see here, this is the suggestion would be to repeat the CBC using a different anticoagulant. So that's what we refer to as the blue top, because that's sodium citrate that they use. And this is what you'll see we collect our coagulation studies on. And one of the other things that you mentioned before, can we do a peripheral blood smear? What would we see in the peripheral blood smear? And I found this interesting because a clinical vignette is someone that has no personal family history of any bleeding, that has thrombocytopenia and just routine blood work. And I'm sure you've seen this at least, well, maybe you've seen this at least once. And these are slides of what platelet clumping would be. And this is what that anticoagulant, the EDTA, would cause. So this is why we see that the platelet count is low, just because it's clumped and it's a spurious result. So that would be the first step, quite simple. Now that we know it's a real non-incidental thrombocytopenia, we can think about the major things that need urgent treatment. And you guys did a fantastic job. You're going to rule out hemolysis, right? Now, someone already brought it up multiple times. TTP HUS should be part of that differential. And I just realized I'm sitting next to 2 future hematology oncology fellows. So they might correct me if I say anything wrong. But what I do think is I need to consider who needs treatment, right? So this is why it's usually recommended that you do a peripheral smear, and even if you do it in the ED, collect levels of haptoglobin, LDH, look at the D-dimer, because you want to know if there's a process of DIC going on, if any microangiopathic hemolytic anemias that may need urgent treatment, like I said before. And you mentioned, Debbie, that we did see some schistocytes in our peripheral smear. And of course, all the other levels that were abnormal and suggestive of hemolysis, right? Now, coagulation studies will usually be normal in TTP and HUS, and we didn't bring it up in our discussion. That's something that will differentiate it maybe from DIC. This is a fantastic resource that I recently discovered, the Calgary Guide. You see, it walks you through the pathophysiology, mechanisms, and the symptoms or lab findings for different diseases. So now you have TTP and HUS, and just as a brief review, you have either ADAMS 13 deficiency, or you have an inhibition or an activation of the attack complex, which is related to some of the questions you asked, and you have widespread hemolysis. In HUS, well, I blocked it so we don't, talk too much about details, but that would be in the setting of an infection. And then you, in TTP, have a failure to cleave those large 1 milligram factor multimers. And if they accumulate, then we see that the platelets aggregate and they form thrombi, and this is a problem. Now, this process can also happen with some drugs because they form antibodies, and these antibodies target platelets. And we'll talk about the common drugs that would cause this, but basically, again, it leads to platelet clumping and thrombi. And this is why we see the different symptoms that, if you remember from like STEP, HUS, and TTP, and this is just a very graphic way of seeing which symptoms are related to each, but let's go back. There we go. So platelet activation, platelet consumption, you're thinking our clotting abilities are reduced. And we see in some cases peripheral, and we'll talk about this later. CNS, again, that microangiopathy and that thrombi that's widespread in different tissues will affect either the CNS, kidneys, and we see those changes. And that's what we're asking about baseline creatinine. Is something that's acute and happening in this case? And of course, if there's a formation of fibrin strands, then we'll see that that causes stress in the cells. There's hemolysis, and we can find all those abnormalities: the increased indirect bilirubin, the increased LDH, decreased haptoglobin, which we don't have to go into today, but it's a very interesting pathophysiology. So now we said this is real. We're excluding hemolysis, which is not the case for our patient, and we'll see why later. But let's say we're just looking at this patient, a different patient, and now we know all these labs are normal. Then we have to think about medications, and we have to think about hypersplenism. Now, some of the medications that are related to thrombocytopenia are quite common. Antibiotics, including Bactrim and other medications, antiarrhythmics, thiazide diuretics, and of course, heparin, right? The hypersplenism is far more common in patients that have cirrhosis. When you have a patient in the hospital, this is something that comes up quite frequently. Could this be a heparin-induced thrombocytopenia? And if this is the case, it could be quite terrible for the patient, and we need to look at their medications and see if there's any heparin in their orders, including heparin flushes that we need to immediately stop. When you have a patient like this, you have to consider the 4 T's. And again, this score, you can use MD Calc. You don't necessarily need to know it by heart, but you need to know what it's calculating and what's involved in the score. So first thing, obviously, is thrombocytopenia. And they're asking about a percentage of drop from its baseline or the lowest level of platelets that we see. And it will get different points for each item. The second thing is the timing. How long ago was this patient exposed to heparin products? Is this causing any problems? Is there any thrombosis as a result of the thrombocytopenia or this alteration? And then, is there any other explanation? What's the likelihood of this being the cause, heparin being the cause of thrombocytopenia? Now, we have 2 different possibilities here. Either our patient is low risk and we need to stop because there's no indication for further testing, or this patient is medium to high risk, in which case we'll have 2 different possible tests that we can do. So it's either immunologic testing, which we all know are the antibodies against platelets, again, these have a high negative predictive value. Or we can do the gold standard, which is the serotonin release assay, which is very sensitive and very specific. It's basically measuring how much serotonin has been released from the platelets. And this does correlate with the degree of platelet activation that could be happening because of that heparin antibody complex that's attacking our platelets. Now, once we know this score, we can rule out whether this is hemolysis caused by any medications or hypersplenism. And in the case that we still haven't found our answer, we can start thinking of ITP. Now, one of the things is ITP is a diagnosis of exclusion. And this is really important because you have to consider any other immune disorders or any other connective tissue disorders, lymphoproliferative disorders that could be causing this. And this is why you'll see, and I'll share with you the different algorithms for the different societies. This is why they recommend for you to check HIV, hepatitis C. It's cost efficient to know if this could be causing the alteration rather than just needing an ITP. We rule out anything related to the specific patient. So if it's clinically significant or if it's clinically relevant, then you would check, let's see, deficiencies, or you would get, an SPEP or UPEP. Now, in most cases, you don't go all the way to a bone marrow biopsy unless your clinical suspicion is very high, and you would stop about here before you call it ITP if it's consistent with the diagnosis. Okay, so even though it's a diagnosis of exclusion, it's more infrequent to do bone marrow and other invasive procedures. So if I were to summarize what I would do for some of these patients, you would say, first, get a blue top, exclude a pseudo thrombocytopenia, and let's check the blood smear. So like I said, if it's clumping, it could be pseudo thrombocytopenia. Schistocytes, we mentioned, could be that shear stress and microangiopathy. Blasts will, like some of you mentioned, reveal perhaps acute leukemia that could be causing this thrombocytopenia. Atypical lymphocytosis, we know some infections, viral infections could cause this. Could it be that you have a consumptive process and then you'll see this where it's reported as large platelets as well? These are just immature platelets that are coming out of the bone marrow. And then we have other more rare autoimmune conditions. And maybe you see, spherocytes and you see other things in your peripheral smear that could point there. Of course, you want to check coagulation studies, and we're thinking TTP, HUS versus DIC. And like you brought up before, fibrinogen and D-dimer would also be something to collect in the ED. And these are just things to consider. And I know that ferritin was brought up before. HLH is quite rare, and I think we don't necessarily see it very often in our units in Mount Sinai West and Morningside. Now, these are the algorithms, and we have, and here we're using the Mayo Clinic proceedings, and you see how we walk through all the labs that we consider ordering so that we can rule out more common things. And then, of course, we go all the way to ITP. But, that ASH will have its own algorithm, and they'll suggest different things and different other labs that could be collected in these cases. This is for you guys to take a look afterwards. The Curbsiders has an excellent podcast. It's like super distilled. It'll bring you to the very basics of what you would do, maybe in the outpatient setting. And same with clinical problem solvers. Although they do bring us a broad differential diagnosis. And I think it's quite interesting just the way they present it as well. If you want to take a look, that's also the possibilities. And now because I know we're short on time, if you have a patient that's critically ill, the main thing, what is my patient's risk of bleeding? And consider that, you have to see if there are any medications, particularly antiplatelets, that you immediately need to stop. So that's one of the first things I would say, just go back to their chart and discontinue medications that could worsen the case. Clinical bleeding doesn't necessarily correlate with the number of platelets that we have. There's so many other things that you need to check. Uremia, age, whether, like I said, any other anticoagulants or antiplatelets, those things might be more relevant than the number of platelets. Is my patient having a chronic, like we said, what are the baseline values? This is acute or chronic. Again, medication review. Am I giving them something that might be worsening the case? And of course, in that setting, if it's heparin, you consider calculating your 4T score. Any recent events? If you guys are in the unit and this is for critically ill patients, did they get a massive transfusion? Did they just undergo surgery, dialysis in the CCU? If they have an intra-aortic balloon pump, all these things could be causing the thrombocytopenia. And then, of course, your physical exam. You need to go up bedside. Now, it's not frequent that I would find a patient with thrombocytopenia that would have purpura, but if you were to check, you check points where there's pressure and you would check the mouth, which is something that we miss, the mucosa. One of the things, if you do see this, then most likely you'd say, well, they are truly thrombocytopenic, and maybe it's someone who may benefit from a transfusion. And I'm not going to go into the transfusion indications, but bear in mind, clinically significant bleeding will come with platelet levels of maybe 20,000, or some even suggest 10,000. Less than that would be a clinically relevant case. But even if you don't have a patient that's super severely thrombocytopenic, think about any other complications. If a patient just underwent surgery, or they're a trauma patient, or even if it's someone that needs a medication, right? You're thinking antivirals for like HCV, or you're thinking they need chemotherapy. That's also relevant to your patients. So they'll just dismiss is thrombocytopenia that's not super severe. And with that, I'm going to stop, Debbie, because I don't know if I'm.
Okay, I'm gonna share my screen again. All right, so thank you so much, Sani, for the very extensive and easier way to approach a patient with thrombocytopenia. So I'm gonna skip this part. So let's talk about what happened in the hospital to him. What is his final diagnosis? So in the hospital, he was started on Lovenox for the splenic infarcts. He was started on broad spectrum antibiotics, cefepime and Vanc, and was given Tylenol for the fevers. And then throughout his hospitalization, blood and urine culture were negative. He did a lot of workup, a monospot, EBV was negative, HBV was negative, HCV was reactive, but was negative in the PCR. He still had elevated LDH and low haptoglobin, still consistent with hemolysis, but peripheral blood smear showed rare schistocytes, which makes HUS and TTP unlikely. And he also had negative Coombs test, so not an autoimmune hemolysis. Autoimmune workup was negative for him. But then Lyme serum IgM became positive. So doxycycline was added. So there was some improvement in the platelets. However, there was still persistence with the fever. So what they did is they sent a peripheral smear with Wright's and Gemsa stain, and this is what it showed. So it has a Maltese cross, which is representative of babesiosis. So this case was a co-infection of babesiosis and Lyme disease. So this patient, so for these two diseases, it has the same vector, which is the Exodus scapularis. Usually the incidence of babesiosis reported would be around June to August. And I saw this patient around August. And he had a recent travel to Connecticut, and the northeast of United States is endemic with babesiosis. So these are the most common symptoms, and all of this was present in our patient. However, because babesiosis is very rare, we won't really think about it. It doesn't really need to have rashes, but if it has, if this patient has co-infection with Lyme, can present with rashes, but this patient did not have any insect bite or any rashes in this admission. So just a quick way just showing you how to diagnose. It can be done through a Wright's Gemsa stain or a PCR test. And for the treatment for this patient, the preferred regimen for him is azithromycin with atovaquone. But in this admission, as you can see, the patient had elevated liver enzymes, and we cannot give atovaquone for him. So instead, we gave the clindamycin and quinine for him. So we started him on that. And as you can see, when we started, the platelets improved from 40s to 226, and his creatinine improved as well. And eventually his liver enzymes improved as well. And he was discharged to complete 10 days of clindamycin and quinine for babesiosis and 21 days of doxycycline for Lyme. And he's following with cards for the Lovenox. He had a metoprolol because he had an rapid during his admission. He had AFib, so he was given metoprolol. So he's just following up with ID cards and hemonc for his babesiosis and Lyme co-infection. So that's it. Thank you guys for participating.
It was a very nice case, just from the discussion and the differential. Great presentation, the way you did it.
Good job, Debbie.
Thanks, Bailey.
And just in case.
And the only thing that Dr. McKelly mentions is that you don't always have to travel to Connecticut. You could get Lyme even in Central Park.
Right.
So just understand that you don't have to go to Connecticut. You could just be going to Central Park and get it. So, and a lot of times people don't know about insect bites. So very nice case.